Good afternoon, everyone, and greetings from a lovely spring Pretoria afternoon. I don't know about where you live, but definitely the birds are waking me up earlier. The honey does as well. I can smell the jasmine in the air, so summer is definitely on the way. Sorry to all the guys down in the Eastern and Western Cape. I heard it's a little bit chilly there, but I'm sure summer will come your way sooner rather than later as well. I don't think there's any load shedding today, so hopefully you can all stay online for the full hour. So please make yourselves comfortable with the 651 other attendees that registered today. We've got 19 disciplines with us. I'm just going to mention the top 5 by numbers. There's 226 psychologists. We've got 98 physiotherapists. There's 70 OTs, 44 speech therapists and audiologists. We've got 39 bios as well. And let me mention 32 registered counselors. Then there's a whole range of other disciplines: podiatrist, medical orthotist and prosthetist, social workers, chiros, optometrists. We've even got 7 doctors with us. Very welcome to the art therapists, the clinical technologists, hearing aid acousticians, homeopaths, phototherapists, and psychometrists as well. Dietitians, I didn't forget about you. So a warm welcome to each and every one of you. Let me start with some introductions, and I'm looking at Dr. Richard Friedland. He might look familiar to some of you. Now, most of you might recognize him as the Group CEO of Netcare. But did you know that Dr. Friedland also has a bachelor's in veterinary science? That might come as a surprise, and I don't want you to worry, because his qualifications and his experience does not end there. He's extremely well qualified to look after Netcare South Africa because he did exactly the same as CEO of Netcare in the UK. He's also a qualified medical doctor and an MBA. Now, Richard, you're frowning at me because you did say I shouldn't go into detail with your CV. So I'm going to stop there, but just a warm welcome from all of us. And thank you so much for making time in your busy schedule. Can you just check? There we go.
It's a great privilege to be part of this, and thank you for this invitation. And wonderful to talk to so many fellow healthcare workers. So thank you very much for the opportunity. And thank you to ProfNet and EZMed and Dion for allowing me this opportunity.
Thank you so much. A familiar face on our screen today is Dion Beige, who's a bit of a late entry. I don't think his name made it to the invitation list. I think Dion just wanted to be in the presence of Dr. Richard, but Dion, that's okay. We still like you, and you're always welcome to join the party.
Thank you. Thank you very much, Lani, and thanks to you, Richard. It's really a privilege having you here, and we look forward to some of your thought leadership concepts on healthcare. So thanks so much for joining us for the conversation.
Excellent. You might know that obviously Dion is the director of ProfNet Medical, and he's also on the executive of the SpaceNet Global Group. I think most of you know me by now. If you don't, I don't know where you've been. My name is Lani Ace. I'm a product manager at the SpaceNet Global Group, and both myself and Dion are both qualified physiotherapists, not practicing anymore. Well, I'm not, but I'm definitely still a therapist at heart. Attendees, the SpaceNet Global Group is sponsoring this event again. It is accredited for one Ethics CEU point, and we're doing it with the support from EZMed and Medici, your very sophisticated practice management and telehealth solution, which is also integrated, as you know. I'm sure you are all aware that the webinars are recorded and is available for you to listen to or to watch. I'm going to share some links with you. That's going to take you to our website, ezmed.solutions, the YouTube channel, there's a podcast channel, and it is available on Spotify. So let me just quickly try and get it here, and hopefully I can share it to panelists and attendees. So if you quickly focus your attention on the chat functionality, it should appear there. While you are on the webinar tab, if you want to go and listen to some of the previous webinar sessions, and this is, I think, our 17th one that we're running, please go and register for next week's webinar as well. It is one that you do not want to miss, trust me. And at the end of this webinar, I'm going to give you a little bit more information about that. But I think I've said enough. If you, as an attendee, want to say something, please use the chat functionality. We'll try and keep an eye on that, or the Q&A functionality. That is available too. Richard, Dion, over to you. I think I'm going to go now. No, but on a more serious note, Richard, COVID-19. It brought so many challenges, especially in the healthcare environment. If you had to summarize, and I think to summarize is a challenge in itself, what were the biggest challenges around COVID-19 that you experienced in the Netcare hospitals?
Yeah, thank you, Lani. I mean, I think we have come out of COVID and we're coming out of it. So hindsight is always a perfect science. But I think going into this, the biggest challenge we faced was how big this was going to be. And we had no idea whether we would have enough beds in South Africa and enough in our network. We had no idea if we'd have enough oxygen, whether we'd have enough PPE, drugs, and whether we'd have the personnel, you know, our own fellow healthcare workers and staff in particular. And so every day we measured these 6 key drivers, or what we called rate limiting steps. And I think having come through it, we realized that as South Africans, we've actually haven't done too badly. Of course, there's been enormous tragedy, and we've seen the most terrible tragedy. We're not ageist at all in Netcare. Every soul that has passed on, we mourn. And that was someone's spouse, someone's husband, someone's wife, partner, mother, father, brother, sister. And, you know, there's been a lot of deaths in South Africa and perhaps underreported at the moment. But we've also had a lot of successes. And I think part of the blessing that we had in coming late into the pandemic was to gain from other countries their experiences, particularly around treatment. You know, we've knocked on the head this idea that you've got to ventilate every patient, particularly when their SATs drop below 93. No, you don't need to. And we've learned about high-flow nasal oxygen and the fact that proning, and you would know this as a physiotherapist, is so critical. And even if it's lateral proning and not just on the belly, and also getting patients to sit because of the VQ mismatch in this illness. And then we learned about steroids. At the beginning, no one was using steroids and no one was using anticoagulants. And so I think our mortalities and our hospital admissions have dropped, and the length of stay as a result of that learning. And so at the beginning, you know, we put our entire network at the mercy and to service COVID patients. And in many ways that prevented ordinary patients being able to come to hospital. And I think one of our biggest learnings going forward is we've got this, not in an arrogant way, because the textbook hasn't been written on COVID yet. But I do think we've got a better understanding of it so that, you know, if we do get a second wave, and I think we will, I don't think any country in the world is going to avoid COVID again. And New Zealand, at 100 free days, has got COVID, and they've got it in Spain and in Germany and in Greece and in Melbourne, etc. I think we're going to be able to handle it far better and far more rationally. And that's what hindsight does for us. I think if you had to ask me what the biggest lesson in this is, 2 things in this COVID pandemic. One is that, you know, healthcare was never perfect before we came into COVID. So when we speak about a post-COVID world, let's recognize that there were huge fault lines in healthcare prior to that. But I would argue that probably one of the biggest fault lines we had in healthcare and still have was communication. And COVID exacerbated that. And often our healthcare workers, and I don't talk about our allied healthcare professionals here, I talk mainly about our specialist body, are very poor in communicating. Now, we've got around that with patients because their families tend to visit them. They can see face to face and get reassurance. My relative, my loved one is okay. But come COVID, where people are in masks and people are in PPE and we don't allow visitors in, this lack of communication was exacerbated. And I can tell you one of our biggest learnings here was that COVID brought around about the most incredible debilitating anxiety amongst patients and their families. I've never seen those levels of anxiety amongst patients before. And it was exacerbated by the lack of communication. And so in many instances, we try to FaceTime with relatives, try to give them an iPad, make sure that they could make contact. And we were one of the first to introduce compassionate visiting, where patients were dying. And we wanted families to come in and be able to say their last goodbyes. And I think in many instances, families that didn't do this were left feeling bereft and very angry. angry at the process, angry at COVID, angry at us because of the inhumane way that this virus has infected all of us. And so the challenge, I think, for COVID was for us not to lose our humanity during a pandemic that threatened to make us all inhumane. And for those colleagues on this webinar who are at the front line treating patients together with ourselves, we know that we look terrific to our patients. They couldn't hear us. We were muffled. We had masks on. We were unrecognizable. And exactly. And, you know, they thought that the worst contagion in the world had infected them. And so this isolation and PPE exacerbated it. And so our biggest struggle and one of our biggest weaknesses, I think, was around communication. And shame on us if we don't learn from that in terms of communicating better. And, you know, a lot of our colleagues said, no, we're too busy to communicate. You're never too busy to communicate. You're never too busy to allay the fears and anxiety of family. And, you know, we saw a lot of elderly patients whose family were overseas, but were able to communicate on a mobile and got some joy out of that. And many elderly people that came in had already been in isolation in these retirement homes or residences. And so they hadn't seen their loved ones, and then they passed on. So the virus threatens us in a way and challenges us in a way that communication becomes critically important. And I think we could have done a lot better, to be honest. I think we began to realize the impact of this, but not early on enough. And I think there were exemplars in our group where people were allowed to come in. And we found patients did better when they had their loved ones talking to them, because many of our elderly patients simply gave up. It was an extraordinary thing to see. And I think this would have made a difference. And I won't talk for too long. I'll tell you the other big lesson is teamwork. Medicine isn't a solo profession. We learned that with digitization and trying to bring digitization into Netcare. We tried to use the Cleveland healthcare model in trying to tell doctors, particularly, lesser allied healthcare professionals, you're used to working in teams. And the best teamwork I've seen is at some of our rehab hospitals like Netcare Rehab. That's the best form of medicine you'll ever find. But in our hospitals, we've operated in silos. And specialists have had their own patients and have not been worried about other specialists' patients. And they were getting burnt out. And so we put them into teams, and it was the best thing we could ever have done. Because when you put a multidisciplinary team together, they're able to communicate better, look after the patient more holistically. And I think shame on us going forward if we don't maintain that team approach. Again, with nursing, but also with our specialists. I'll stop there.
Thank you. So there's a couple of things that I want to unpack in a little bit more detail, especially around the teams, the communication and humanity, and obviously the learnings and how we can apply something else in the future. And we don't know what that future looks like yet. But Deanne, I'm just quickly looking in your direction. When you were still a physio, you obviously had a lot of rehab experience in some of these facilities. What's your take on this? Do you think as and when a team comes together, they can actually better the outcome of a specific patient versus working in this siloed approach?
No, thanks, Lonnie. And I'll declare my interest and our common path with Richard from many years ago. I was, in fact, involved in the rehab practice with Rita Hen and Partners at Netcare Rehab Hospital. And it's just been such an incredible journey to see the support both from the hospital themselves and then the various disciplines coming together. When we started off, we were just a group of physios, and we expanded into occupational therapy, speech therapy, and the practices continue to grow over the years. Including social workers, psychologists, and so on. And it's just been phenomenal to see that growth. And what we were able to do in that space is firstly, litmus tests. What does a multidisciplinary team look like? How do we work together? How do we actually coordinate the care? But then also starting to say, I did a concept paper on the interdisciplinary team approach. And I think people are often using those two words sort of interchangeably. But I think the fundamental difference when one looks at moving from a multidisciplinary team to an interdisciplinary team is one where the patient actually moves into that center. The patient is involved in setting goals. The patient's involved in their rehabilitation process and the engagements and what they're looking to do. I can share examples where we have often gone textbook and said the best interest of this patient and this level of spinal cord injury should achieve the following. But how does that harmonize with the patient's actual goals, and how do they pace that, and what is their ambitions? So I think it's very important to look at putting that patient center, rallying the team around that, including the medical doctor, the allied healthcare professionals, where we're all equal in function but different in value in what we actually bring to the party in the patient's best interests. So that's the interdisciplinary approach. But what that obviously calls for is, as Richard says, communication is so important, vitally important. And that communication between the team, writing joint reports, coordinating what the plans are. And there's strong evidence to support the interdisciplinary team as far as getting better outcomes at a more efficient and cost-effective way, right from rehabilitation to cardiac rehab and management of the cardiac patient and so on. So there's multiple examples of that. So I think it's a wonderful journey, and I think the coordinated team approach that is often displayed in rehabilitation settings really does set the bar high.
Dion, I'm preempting a question here. It doesn't pop up yet, but I'm sure it's coming. What's the difference between an interdisciplinary versus a multidisciplinary team?
Yeah. So I think, where a patient has multiple different disciplines taking care of them, we will talk about the multidisciplinary team. But that team could be a fragmented one where the occupational therapist would come into the facility and treat the patient and go and treat the rest of her patients at her outpatient clinic or at a different hospital. The physio would come and go, and it's not necessarily a coordinated approach, but the patient is getting a multidisciplinary complement to their rehabilitation or their intervention. But it's that interdisciplinary which brings that team together with the patient-centered and the practitioners working together on common reporting, common communication, and common goals, as set by the patient. And I think what is really critical in all of this is we used to have, and I'm sure it's still continuing, is patient meetings where we'd meet with the patient and their families to actually spend time to sit down and actually calibrate and say, well, this is the diagnosis, this is the prognosis, this is where we anticipate moving to. What are your goals? What does your home environment look like? What does your work environment look like? What are your aspirations? Do you want to retire now? Or do you want to get back to work? And how do we shape your interventions and your treatment modalities around that to get the maximum function as guided by the patient?
Perfect. Thanks for that summary. Richard, is that something that you've seen in your hospitals, that there might be a lack of an interdisciplinary approach versus the siloed approach?
Yeah, absolutely. I think that the only time you see this real interdisciplinary approach, as Dion has spoken about, is in our rehab setting. And often when I refer patients into that setting, I say, you're going to see an example of how medicine should run. Because that's the way medicine should be. The patient is at the center, and we're putting the person's, what we call person-centered health and care, at the center. And it's not about the individual egos or the individual specialists, etc. And when you have that firm approach or that group approach, you achieve so much better. You know, in the United Kingdom, when we went in early 2000, when I moved across there to set up these waiting list initiatives for the NHS, we put a whole team firm in place to do the hips. And the challenge at the time was how now, of course, we can do it a lot less, but can we get patients out in 5.5 days for a hip replacement, when at the time, the average length of stay for a hip replacement was 13 days. And so it was critical to have an occupational therapist on board who did the pre-examination of a patient in our clinic. We had a one-stop clinic where they could determine, do they live in a semi-detached or bungalow? In other words, did they live, were there stairs? What kind of seat did they need on the toilet? How were they going to manage after the op? It was critical to have physiotherapists on the team. It was critical, you know, to have everyone in. And we led a team because we were running hip operations almost on a manufacturing basis. That some days a nurse would lead the ward round in the morning and do nurse-led discharge, or the physio, or the OT, or the surgeon, or the GP. And it brought an enormous camaraderie together because we all owned that patient. We all took responsibility and we all knew the criteria. And there we were mobilizing people. It was unheard of within 24 hours. Now, of course, today we know it's different. But kind of 20 years ago, this idea you're going to get someone up and the physio is going to mobilize you immediately and we're going to get you out in 5 days. And it was that team approach that got excellent results. And I'm somewhere in this so we can be able to achieve that. I think the reimbursement model itself needs to change. Fee for service, everyone is after their own billing. If you have a kind of global fee or an alternative reimbursement, you all share in that for that patient. And I think that's the ideal, but there's a lot that needs to change. And I'll add one more thing. We're digitizing. And the beauty of our digitization process, the electronic record, is you can see exactly what the physio or speech therapist has said or not. And I've seen this with a case of stroke. Instead of wondering what is the speech therapist said about this patient's aphasia, you've got it in the electronic record, and you can isolate all of that and you can see it, and it hopefully builds that. So enablement through digitization, I think, is important as well.
Sure. Just rewind about 2 sentences, and there's a lot that you said that we need to unpack a little bit more. I can see we're going to overrun here again this afternoon. You were talking about alternative reimbursement models versus fee for service, and I just want to pause there for a second, because I know, Dion, you've got a very strong opinion around that. Richard, did you say that there is benefit, or there might be benefit? Are you a believer in alternative reimbursement models, and do you think it's part of the future of healthcare?
I think when we start taking responsibility for outcome and we can measure it objectively, absolutely, it's exactly the right thing to be doing. And I think that if you're prepared to take risk and be able to measure outcome, and to Dion's point earlier, to be realistic about a patient's functionality and what they can and can't achieve, and give them those goals, I think that leads to better healthcare longer term. At the moment, healthcare is very siloed. And as a result of it, when you look at, what does the post-COVID world look like? Well, the pre-COVID world looked terrible. Healthcare costs spiraling, and yet outcomes not commensurate with it. Yes, since the 1970s, we're living a decade longer, but we're spending 4,000 times more on healthcare, literally, than what we spent, or 400 times more than what we spent in the 70s. And we haven't controlled non-communicable diseases. So there is this interdisciplinary approach, which I think will benefit healthcare. There's no question about it.
So before we start talking about what's lying post-COVID, if there is anything like post-COVID, Dion, just shortly, your opinion about alternative reimbursement models and where that is sort of lying in the future of healthcare?
Thanks, Lonnie. I think I'll first take the non-private sector approach and just highlight that the National Health Insurance Strategy, right from the green paper, the white paper, and right up to the policies we're seeing now, firmly embraced alternative reimbursement models from the start. I also want to compliment our public sector practitioners, because if one looks at how coordinated care happens in a well-organized and a well-run public service, you do find the disciplines working together. They share a common lunch area and a tea pause area. They are brought together. They share common CPD activities and ward rounds. And you have the disciplines really rallying around the patient and the doctor, teaching them and showing them what is going on and what everybody's role is in the team. So in the public sector, I think we've got some lessons to learn from where things are done exceptionally well. You look at the Western Cape Rehab Center and what they've done in the public sector in rehabilitation is absolutely phenomenal. I think the public sector's got a lot to learn. We can learn from there too. The alternative reimbursement models are baked in. They use examples like capitated fees in the NHI documentation, but certainly it's a way to go. The fee-for-service model is one where, if I have to really break it down to the basic principles, is for you as a patient, all I need to do is a certain procedure or a certain intervention or treatment. There's a code for that, there's a descriptor for that, and there's a fee for that. The fact that I've done it means I can bill it, and if there's benefits, I'll be paid for that, regardless of the patient's outcome. I could be doing it inappropriately, I could be doing it too much, I could be doing it and getting 0 outcomes, but you know what, there's no risk in it for me. All I need to do is make sure I go through the motions and bill for that treatment. Now, I think we can all agree that that's not necessarily in the patient's best interests. Where it comes to alternative reimbursement models, as Richard very well put, is that we now need to start looking at risk-sharing models where the actual healthcare practitioners are also part of this risk-sharing model, where they're saying, I'm going to put risk in it, I'm going to put skin in the game. I'm going to be saying it's going to cost so much to get a patient from this to that, whether it's pain outcomes or functional outcomes or discharged, able to walk stairs and able to cross the street fast enough to be safe. Those are the outcomes I'm looking for. That's going to cost X. And if I can get that right in 2 days, then I've made some margin on that. If it takes me 2 months to do that, that fee is still appropriate for the outcome that is being paid for. So that's the mind shift change that we should be looking at. There's an example of and I won't quote a country as such because I think it's become a bit of an urban legend, but I think it certainly drives this principle home. A GP looking after a group of patients in their population. 100,000 patients get allocated to that GP, but the GP only gets paid an amount per head of those 100,000 while they're healthy. The minute somebody gets sick, that money is withdrawn and he doesn't get that money for that sick patient until he gets that patient back to health. It is then his interest to make sure the patients remain healthy, that he does interventions, that he does education, that he does screenings, that he does flu vax, whatever else there is to prevent the sickness, but to keep them healthy in the first place, because that's what he's incentivized to do, is take care of their health. So that's just some examples of how we can just start shaking our thinking around just the standard ongoing fee-for-service model, which I don't think is in the interest of the patient.
I'm going to note that as one of our future webinar topics, because there's a lot that you just said there that we need to unpack.
Yeah.
But guys, we're talking about what's happening post-COVID. Richard, is there going to be something like post-COVID, or do you think healthcare will return back to normal, pre-COVID days?
Yeah, that's an excellent question. I don't think it will, because I think that COVID exposed something quite dramatic for us. You know, we've never really taken respiratory illnesses that seriously. And none of us in the healthcare sector and also in business have taken seriously enough occupational health and safety, and the safety of our workers and the safety of healthcare workers. And we've seen the tragedies unfold. You know, we've lost 13 healthcare workers on the front line, and we mourn the loss of each one. And I think that this risk assessment of being able to make sure that you're fully protected, that you've got enough PPE, is a critical enabler in going forward from a practice point of view. I think we're always going to have what we call background COVID. We're going to have COVID in the background, maybe not large outbreaks, but until a vaccine. Sorry, we have energy saving in our offices, and now the lights come on. We have, correct. And we also have, you know, I think that we're going to have to get used to treating patients with COVID and taking the necessary risks. In our way, we're going to kind of try segment that into certain specialist centers. And I think it's a long time before we see a vaccine, probably about 18 months to 2 years, that might give us some form of protection. I think patients are paranoid and petrified, and rightly so. They've heard horror stories, and you see this in the United States. You're seeing it elsewhere in the world, that there's been a very slow, reluctant return to normal, or the new normal. And so I think virtual consultations and telemedicine and it's going to play a much bigger role. I saw some statistics out of McKinsey that said that 14 to 15% of people were using telemedicine before COVID, and it's gone up to probably 40 to 44% post the COVID or during the COVID. So I think we've got to embrace those new technologies, and it's all part of empowering patients with their own records and their own history and outcomes.
Is virtual consultations already used successfully within the Netcare Group?
So we've been rolling that out. We have we have a voucher system. So we have two elements. One is that we've enabled a technology so that GPs can do virtual consultations within the Medicross environment. We've also got about 550 of our specialists who are now wanting to participate on a virtual platform. And we want to be able to make that available to everyone so that they can use it. Doctors are scared, patients are scared about the confidentiality of data and that it's fully encrypted and there aren't going to be breaches in that. And obviously, from a popular point of view, we've got to be absolutely careful, but we're comfortable. And we think that that changes the paradigm. COVID has taught us how to work differently. You know, you don't have to stick to working hours. You can get onto Zoom for a consult. You can get onto virtual consult. It doesn't have to be, I need an appointment at 9:30 in the morning, or I've got to get in my car and do it. And I think we've all got to look to embrace that. Absolutely. So we have enabled that, and then we've made vouchers available that for GPs, both virtual consults and also ones in front of a GP on the FNB eBucks platform. And we're looking to roll out vouchers for physiotherapy and for audiology, for all of the services where people don't necessarily have a medical aid, but want to be part of a network and be able to go to healthcare practitioners.
Exciting times, exciting times. Dion, I know you're burning to say something about integration and security and practice management systems versus telehealth platforms. Let's have your view on this one.
Absolutely. I think from a security point of view, and there was a question actually asked in the chat stream on POPI Act and sharing of information between practitioners in the interdisciplinary teams. And absolutely, that's a great question. I think we need to ensure that we share that information responsibly and appropriately. And it doesn't mean that when you share information, you send a whole lot along and the next practitioner has access to everything within that record. It needs to be the appropriate information that's being shared. And what we've done very nicely within EZMed is, as you're sharing that through your multidisciplinary teams, which we've now knitted together, you're able to share that information within the POPI regulation, allowing the patient to consent to those sharing of data, and that the appropriate data is shared. You can't be sharing all your clinical notes. You might have some that are appropriate for you, but others that are part of the team report. You might want to be sharing the patient's information as their demographic information so that you don't have to recapture them in the other disciplines that are complementing. And you're able to share that also quite comfortably, and as well as diary sharing so that you can actually coordinate. So when the patient, the patient's actually in for occupational therapy from 9 to 10. So let's set the physio appointment from 10 to 11. So we've done that in an astute way. But what is critical
with patient consent. Sorry for interrupting.
Absolutely. As I was about to say, the patient needs to consent and needs to be POPI compliant. But we've actually taken it a step further because as we've engaged with our telehealth elements, we've partnered with Medici, which is based in the US, in Austin, Texas. And their regulatory requirements, I think, take POPI to the next level. And they have HIPAA compliance requirements, which we've now embarked on internally, and we're adopting HIPAA standards on our security within our systems as we roll our systems out, not only in South Africa, but internationally as well.
Excellent.
I would just add on that the other aspect, because we've had to go through this compliance for our electronic medical records, and we've been using Deutsche Telekom as our platform. So we comply with the European GDPR requirements with like HIPAA, it's POPI on steroids.
Absolutely.
And one of the most important things is to have a full audit trail of all of the data you share. So that there can never be an accusation that data was shared with the wrong parties, or perhaps the wrong data was shared.
Yeah, I think if I can just add on to that, and we've seen it now with various breaches that have happened that have been in the press, and even within the healthcare space within South Africa, fortunately not with this hospital group, but with another one. And we know that there's this risk, but often we think it's a hacker sitting late at night with a spotlight on top of their heads and they're hacking away trying to access information. But I think what's really important for those on the webinar is to consider is that a large majority of these data breaches actually happen within the organizations from staff. So it really is important that you contract your staff appropriately and you make sure that they understand the security requirements. The Health Professions Council's got a booklet on protecting patient information, that they sign these documents, and that you also ensure that your internal security and your passwords are managed and maintained, and that you don't have 3 people using the same username and password to access elements of your system. So please make sure that you got that cover in place as well. That's often where the breach of data may occur.
Yeah.
There's obviously a lot of providers, sorry, Richard, that complains, and the patients complain about the wearing of the PPE equipment, whether it's a mask or a visor or something like that. And this, again, is where telehealth is a solution. If it's the appropriate patient, you can actually treat their clinical condition via a digital platform. That is absolutely your answer, because you can see your therapist and the therapist can see the patient. And I think that is so crucially important.
Absolutely.
Yeah,
Richard, you were saying something.
Some people don't want to communicate like this and they find it difficult, but once they've tried it and they can communicate on a safe channel, WhatsApp itself is not necessarily a safe channel, maybe Telegram is more, but you've got to develop these channels to communicate, and I think it makes the medicine and healthcare a lot more seamless. And that's what COVID has done. We don't all have to come to the office and be here between 7 and 5 or 8 and 6, whatever it is. We can certainly operate remotely, and as professionals, we can do that, and as healthcare workers. Of course, there comes a time where you can't give physiotherapy over the internet. You're going to have to give therapy, and we understand that. But I think as a way of attracting patients and retaining that communication is absolutely critical.
It just improves the access to healthcare. So it's better having access to healthcare than not having it at all. Yes, it's on a new platform. And I think both parties need to get used to it. But Dion, you've got some lovely examples where patients and providers have actually gotten used to using virtual platforms of a discipline or two that you never would have thought would be able to use this. Can you give us an example?
Sure. I think firstly, if we have to look at some of the disciplines, psychology has most certainly led the way as far as their engagements with patients using technology. I think for even before COVID, I know of a few psychologists that were using Skype to actually consult with their patients and to follow up with them. They might have a patient that immigrates and the patient wants to continue with the care from that psychologist, and they would then continue to do so. The Health Professions Council has obviously changed the regulation relating to engaging in even new patients to a practice. And they also state that, as long as you are registered as a healthcare practitioner in both the territory that you're practicing from, as well as where the patient finds themselves, you can actually engage in those sorts of platforms. So the world has opened up quite a lot for us. But if we have to kind of describe those disciplines like psychology, dietitians, and so on as consulting disciplines, you have the other disciplines that we can typically call physical disciplines. Examples of physiotherapy, podiatry, biokinetics. And I think the first response we found when we started offering our solutions into the market was, but hang on, this can never work for me. I'm a physical discipline. How am I supposed to treat my patients over a line? But the point is, we've seen a podiatrist, for example, I think she's on the call today, who was very proactive in saying, let's think out the box and see how we can actually manage my patients through embracing technology like Medici. And what she did was actually reach out and follow up with the patients and see how they're getting on. Do they need to come back to the practice for a review or an assessment or an intervention? Running remote clinics in a mining hospital or mining area, for example, she was able to reach out, engage with the patients, triage and decide who she needs to see first and actually plan her day accordingly prior to going out. So her practice has become a whole lot more efficient, much more coordinated, and the patient experience has been one that, it's not that come to my practice and I'll see you, but otherwise, we're not actually going to make contact. You can actually reach out and engage and be comforted by the support from the healthcare provider outside of the traditional places of service. And I think that's been exciting. COVID, if it's done anything, has actually catalyzed both healthcare practitioners and patients into adopting technology that was in fact there already. But the change management has always been difficult. And this has really pushed us into the space where we suddenly look back and realize, but hang on, this can actually be done. And it actually works. I mean, this webinar is a prime example. Where would we have an opportunity to speak to Dr. Friedland and have him on a podium where we can do this in the comfort of our own homes? It's amazing.
Thank you, Dion.
Can I make a comment there, if I may?
Yeah.
So, I think one of the global trends that we're seeing is this move away from talking about patients to talking about people. The World Health Organization said, these patients were people before they came into hospital and they're going to be people afterwards. So let's talk about people-centered healthcare. We've gone one step further, and of course we've plagiarized the best of what's available in the United States at Cleveland and at Suter Health and God knows where else. And they talk about person-centered because healthcare needs to still remain, an individualized approach to people. And we've broken it down into person-centered health and care because there will be a time where you need to look after the patient. That's the care part, but there is an obligation on us as practitioners to keep people healthy as well. And often we're very siloed in just looking after that illness in the hospital and never really worrying about what happens to them before or after, as therapists or as doctors or whatever the case may be. And so person-centered health and care is kind of the new mantra that we've kind of adopted in Netcare. But one of the most important things we've seen is that you have to enable people with records. And the best way to do that is on a digital platform. And I think the more patients and people that you're able to give them their records for life, and Kaiser Permanente do that in the USA. If you ever want to go and look at an exemplar, Ping An in China does it as well. where all of your records are contained from cradle to grave on this record. And they've got wellness at the center. And so patients are fully empowered. And so it adds to this kind of digital milieu where you want to virtually consult or you want to have a teleconsult and you're getting your records. And I think that's where the future of healthcare is going.
Sure.
And we're on that journey. It's a 3-year journey for us in Netcare. And yes, we know there'll be a large proponent of people that still, want to do things manually. But it's very powerful when you've got your records and you don't have to repeat blood tests. You don't have to repeat chest x-rays. You don't have to have unnecessary procedures done because it's all there. And often we've seen this, someone has a knee operation and they're okay for 2 or 3 years and suddenly they fall. So they go back to the specialist, they're not available. They see someone else. Well, what happened? Well, I don't know. The doctor operated and there's a big scar here, etc. Well, as opposed to, well, here's my record. Yeah. And by the way, there's the digital of my MRI and you can see I had an acute anterior cruciate ligament repair and this is what happened and I'm allergic to morphine or whatever the case. Mm-hmm. And so that's the kind of healthcare that really is empowering that we've got to all aim for.
Richard, on that point, I think, again, we've spoken about the moving away from the siloed approach when it comes to healthcare practitioners and managing the patient. But again, I think that there are so many different systems and entities that are setting up electronic records. And until such time as that is a global record that follows the patient, regardless of which medical scheme I belong to, which hospital I go to, or which practice management system I use, I should be able to use that information interchangeably across a broad spectrum. And an example is the Dubai Health Authority that introduced electronic health records in 18 months. But it was a very authoritarian top-down instruction to say this is what will happen. But that was part of the success of that. How do you see us doing that in South Africa without any sort of government direction on this or legislation that shapes this?
So I think there are two issues here that you raise. One is a health information exchange. And we're part of the founding members of that with the other hospital groups and some of the medical schemes that will allow information to be shared across hospital groups, providers, specialists, practitioners, therapists, whoever. And that's an overarching health information exchange and allows the free exchange of that information. Mm-hmm. And that is progressing. It's taken a bit of a backseat in COVID. The second is a kind of electronic health record that works. And, one of the things that won't work in South Africa is a top-down approach. Mm-hmm. And so we've had to individually customize our electronic health record, working with doctors. We've been running a pilot at Mill Park. I think what we recognize now is that there's going to be a far greater adoption post-COVID because people now realize there's a huge advantage of looking on my tablets as to what's going on with the patient than having to put on all this PPE and go to the bedside. Yeah. And if another colleague, for instance, is looking at it and they're part of the team, why shouldn't I do it over a cup of coffee in the morning? Mm-hmm. And what we found with electronic records is that often doctors come to the bedside and we put industrial engineers, and I don't want to go into the detail, but I can tell you that we put industrial engineers into our hospital to measure the time that we spend writing notes and talking to patients. Mm-hmm. And 50% of the time an ICU nurse spends in one of our ICUs is taken up writing notes and filling in forms. 50%. And that's not interpreting the data. So the point is when you can get all this data from the machines, then our registered nurses, our most qualified healthcare worker around the patient's bed is able then to interpret the data and engage. And imagine if we could speak to the patient, suppose, no, we're writing down the results every 15 minutes. Yeah. And, this is the problem that we have with healthcare. Likewise, doctors coming into a ICU, into a room, or maybe it's even with some of our therapists on the line here. You're busy spending half your time looking through the notes and checking what this one's written. You can't even understand it because half of it is rubbish. And I don't say that negatively. And I'm going to come on to why I say it's rubbish in a second. Mm-hmm. Instead of saying, I've already seen your results. I've seen what the doctor ordered. I've seen what the speech therapist or physio has done. And I saw your bloods. And now I can have a conversation. Well, how are you? Sure. How are you feeling today?
I think to add on to that,
kind of healthcare that we got to break up. When we audited 166 files, in order to prove this to our board, I had to take this business case to our board. And so we had independently audited in Europe 166 files. We found that an average file in a hospital, it looks like that, but it's got 28,000 data points, right? Only 2,300, about 10% are unique. So then you say to nursing staff and others, well, why are you writing all of this? CYA, cover your, okay? And the point is, you do that for medical legal reasons. Now imagine if all of that's been captured and you're capturing or interpreting the data. That's the kind of healthcare we've got to move into.
Yeah.
Because we kind of I maintain we're managing records and we're not managing patients.
Sure.
And we're worried about medical legal issues, etc. And so this virtual care, this digitization, this is a whole new way of embracing a different type of healthcare. And I think it's upon us, folks.
That is so exciting, and I think you can see my excitement trying to jump in there. But I think once one has that data, I mean, I won't use all those cliches of AI and so on, because I think that's neither here nor there about what does that mean for me as a practitioner, for the patient. But also in the McKinsey report, there was very interesting view on the healthcare ecosystem and how we move forwards. But that data that's captured, I think, should be surfacing out of that and giving us actionable insights. The data is there; it's noise. But what does that data accumulate to say? What does that tell me as a practitioner? What does that tell me as a patient of what is the actionable insights that come from this data to say, you need to do the following proactively. You need to understand you're at risk of the following, or the following intervention is what's required in this space. I think that's where the exciting is.
So Dion, you know, we've called our strategy person-centered health and care, and we've broken up healthcare into health and care because they are distinct, and we want to be able to focus our organization on wellness, because generally in ours, we don't do that.
Okay.
And then that is digitally enabled. In other words, we put the digital tram lines, and that is data driven, because it's those data insights that are going to tell you, listen, we got it wrong. You try analyze an ICU chart. It'll take you hours. And then you know what happens in our hospital, and I'm sorry if I'm hogging this space, but I'll tell you exactly what happens. And our industrial engineer showed us. A nurse comes in, it takes 55 minutes to set up the ICU chart in the morning. Every 15 minutes there are new inputs. And we draw these beautiful graphs and diagrams. There's huge amount of information on this enormous chart. And then at the end of the day, it's all folded up and put back into the record underneath the table. And for our industrial engineers, they just couldn't believe it. You create this work of art, and there's no possibility, no one can check it. Whereas on an electronic record, you can do that and you can gain those insights. Absolutely. You know what we've learned in COVID? We don't have to ventilate every patient who's got SATs below 92 and 93. Wow. You know, before COVID, someone comes in, their SATs are below 90. Quickly, we're going to ventilate. Nonsense. Prone them. Put them on CPAP. Put them on high flow oxygenation. Try something else. Because it wasn't based on science. And I think these insights digitally will help us. Yeah. It's the same as we always used to give people blood transfusions if their hemoglobin dropped below 10. It was a one-page article written by two Navy surgeons, US Navy surgeons in 1942. And everyone took it as the gospel thereafter until we proved that actually you can survive with 6 or 7. That's it. So that's what data is going to allow us to do and get better outcomes for our patients.
Absolutely, absolutely.
Dion, you've been trying to say something, or am I wrong? Did I read you wrong there?
No. I'm fully on board, and I think that's just the beauty of electronic health records is how we actually link that all together in a health information exchange, and how we actually pivot that data to give us actionable insights, both for the patient and for the healthcare practitioners. And as Richard says, just being able to pivot back and say, well, this is what we thought worked. Did it in fact work? And how do we actually pivot around that? How do we flex and respond to what the data is showing us? So that's crucial. I don't think we're doing enough of that. I think we've got a story always when it comes to an intervention to say that the physiotherapist had the following intervention for non-mechanical low back pain at the cost of the following. And that's where the story stops. But the question is, at the cost of the following, to get what outcomes, to move the patient from being at home and not able to go to work to going back to work with a pain scale that's below 3 and allows them to function. What is the outcome we're actually getting? And this is all data driven to actually pull that whole storyline together and then also feed into that what is the best practice guidelines. what is the evidence around what should be done, and what is the evidence about what we've seen, and what is really working, what's not working. Even in my own practice, I should be able to do that in my own practice with the right data. And so that's exciting. I mean, we continue to move in that space and enable that all the time.
Absolutely.
Yeah.
Dion, there's just a few questions that came up with regards to the security and the information storage and accessibility of data. No, it's fantastic to have data, but storing it in a secure environment, that's a different story. Can you just briefly explain to the audience here what we've been trying to do with our data?
Sure. I think sorry, this is a very long conversation. I'm going to just keep it very short. But I think the most important thing is that when you are storing your data electronically, that it's stored securely and safely. There are standards around that. There's ISO standards around that. We obviously have to be cognizant of POPI and better still HIPAA or European standards on that storage. But also just something to keep in mind is, where is that data being stored? Is it being stored locally in the territory in which you are practicing and operating in? We often save stuff to the cloud, and we say, I'm going to quickly put it in a Google Drive or a OneDrive or somewhere. But where in fact is that storage center? Because if that storage center is sitting in Ireland somewhere, that data is then under jurisdiction of that region, that territory as well. So we have to be very careful about that. The good news is that we're finding the large providers of cloud services moving to South Africa. We've seen Microsoft bring servers here. We've seen Amazon bring servers here. And that's important for us, because it is about the territory and where that information is and what the governance is around that data.
Okay, thank you.
I'll just add this, if I may, for a second. We chose to use physical data warehousing for our data, given the suspicion by specialists it was going to be lost in the cloud or somewhere. And so we've gone that route initially. You know, when you're the pioneer in something and you're doing it for the first time, I think people that will follow us on it will do it through the cloud. But I think the other thing that we learned in our due diligence with many of our most vocal specialists, I'm not going to allow my data to be stored here, and Telkom's not, or BCX or whatever else is not going to. Then you go into their consulting rooms and their files are all over the place. One of them complained to us. He said, "Can you help me? Because the mites and lice and God knows what else have eaten through half and the dampness." So the current situation, it's like healthcare. It ain't that pristine prior to us.
Yeah.
Can we please get rid of the yellow manila envelopes?
There you go.
James, I just want to steer the conversation in a completely different direction. I am just watching the clock here. NHI, Richard, can we quickly have your thoughts around that? I know it's a long discussion, but let's try and keep it brief. Just what's your opinion? Is it going to work? Is it not?
I'm glad Dion referred to some of the excellent practices in the public sector, because this firm approach, team approach, classically, we reverted back to that. Even with our nursing, we've developed teams. But you've got to realize that not only is healthcare broken at the moment globally, but we have a unique challenge in South Africa that we have two worlds of the haves and have-nots. And we cannot build a healthy nation, a sustainable nation, without looking after the healthcare of South Africa. And so our view in Netcare is you've got two approaches in the private sector. You can choose to have an exclusive approach, which is purely for those that have healthcare and have medical aid, or you can choose an inclusive one. And we've chosen the latter. And so we embrace this idea of some form of national healthcare. We have got to provide healthcare to the broader South Africans, from a sustainability, from a universal rights perspective. The question is how we fund it. We believe there is an enormous opportunity for the private sector to help provide healthcare, particularly for those that are uninsured but employed. And there's a large segment of South Africans. Now, it's a swear word because it's called social health insurance and not national health insurance. In other words, employees partially fund that healthcare. Instead of saying, I have no responsibility for my healthcare, well, post-COVID, you've got a lot of occupational health and safety responsibility. And you've got to do, assessments on vulnerable employees. You're going to be checked on it. I mean, it's pretty onerous, etc. And so looking after the health of your employee base is important. I think that helps government in terms of the overall funding. And I think the big question about NHI is not providing the healthcare. I think we've got enough of a budget, to be perfectly honest, if it's appropriately spent. I do think it's how we fund it and what are those mechanisms around it. But I think all of us as providers should see this as an enormous opportunity. There may be threats to medical schemes per se, but certainly as providers, our services will be sought after. We saw it in our negotiations and our with government now around COVID, because government thought at some stage, we all felt that we were going to treat public sector patients. We came out very clearly in March, at the end of March, and said we will do it on a cost recovery basis. And we negotiated something with the Western Cape government, with Gauteng and others, which I think has the tenets of a team approach, of a multi and interdisciplinary approach, but looked at what could be the art of the possible. The big question is who funds this and where are those funds collected? But we're a full supporter of NHI in terms of building a society we can all be proud of and one that is healthy and sustainable.
Thank you. Dion, just shortly, your view on NHI, keeping an eye on the clock there?
I'll be very short. I think Richard said it exceptionally well, and I think we all have a responsibility to embrace broadening the reach of healthcare and taking care of the citizens of this country. How we do that it needs to be astute. It needs to be an appropriate way. But I think there's incredible skills that we need to be translating across that divide that Richard spoke about. I think it is in principle a great idea. If you look at the documents and what the intentions are around that, I think private sector can learn from that too. I think I've expanded on that point, but it is about the how and making sure that we appropriately spend the money in the right places and manage those coffers appropriately to ensure that the patients get the care they deserve. But absolutely, I think we need to step up and step forward into NHI and not run away from it.
Yeah, thank you. Dr. Richard, Dion, I wish there were more than 60 minutes in an hour, but we are sort of closing here. There's about 4 or 5 minutes left. Thank you very, very much for an open, honest and frank conversation this afternoon. I really appreciate that. I really feel that I think there's a meeting of the minds here around person-centered health and care, like you rightly said, Richard. And I think there needs to be a massive shift in the way that we practice healthcare, especially in the future. And making healthcare available to the majority of people, if not all, via different models and platforms. And that would include virtual consultations on digital platforms going now and into the future. And I think that's a hard lesson that COVID maybe taught all of us. I will come back to you for some closing remarks, but just a reminder to all the attendees, should you wish to view any of our previous webinars, they are available on 3 different platforms. Talking about platforms, I'm copying it now, I'm pasting it in the chat functionality again, should you wish to go and look at it, either on our website, EZMed.solutions, our YouTube channel, podcast, or Spotify channel. On the website itself, there's some really interesting documents and articles around how to win over your patients' trust to start engaging on a digital platform. That was written by the Medici CEO, Neil Kinsley. So it's very, very interesting, and it's very practical tips that you can use and apply in your practice. Dion, you mentioned EZMed and Medici. We know it's a sophisticated, integrated practice management system and a telehealth system. If any of you are interested or just want a little bit more information, please contact us via our website, EZMed.solutions. Now, I promise next week is going to be a very interesting webinar. I can tell you that Dr. Michael Moll will be joining us for the webinar. I think that is on the 3rd of September, if I'm not mistaken. Did you know that his wife is a physio? I only found that out recently. So one of his many visions is to try and provide personal, affordable, and quality healthcare through immediate access to the majority of South Africans and other people as well. And he's trying to achieve this with a mobile digital health platform, which is called Hello Doctor. Now, Dr. Moore will also be talking to us about how to beat COVID, both in the current healthcare environment and in the future healthcare environment that we're going to be finding ourselves in hopefully very soon, if I can say post-COVID curve. So please book your seats now on EZMed.solutions, navigate to the webinar tab. Spaces are limited, so get in there quickly. And it almost sounds to me as if today's conversation is opening the door to a series of future webinars, and it might be around this topic of the future of healthcare. So please watch this space. We should have some really interesting speakers with us within the next couple of weeks. Dion, Richard, I haven't forgotten about you. let's go for some last thoughts. I know there's 2 minutes left, so let's keep it short. Maybe Dion, I'm going to start with you this time.
I'll keep it very short. I'm super excited about the future of healthcare, the embracing of technology, the bringing together of the different role plays in the healthcare ecosystem. One of the webinars, we will talk about that and how do we bring healthcare practitioners together. If it's not in the bricks and mortar and heartbeats around each other, then can we do that virtually? Can we do that through virtual networks? Can we coordinate care through these platforms? So I think there's a lot of exciting things to do. We just don't have enough time in the day to actually do all of these things, but we do as much as we can to help drive forwards. And as SpaceNet Global Group, we're excited to empower the technologies that bring these forward to change the lives of patients and healthcare practitioners. And I also just want to say thank you, Richard. It's really been an honor. It was really great having you here and getting to know the man behind the name. It's your name precedes you and your reputation precedes you. And it's really great having you here. Thank you so much.
Thank you so much for the privilege of being able to share some ideas with you. And I want to end off by just recognizing Pamela Hansford, who's posted a note saying that as a quad in lying in a spinal unit, she knows exactly how patients should not be treated. And Pamela, one of them on my CV that I never speak about is that when I was studying veterinary science to earn more money, I was a male nurse in the spinal unit at night. HF Woodford is today Steve Biku. And they employed these male orderlies so that we could turn patients every 2 hours. And so I want to come back to what you're saying is that at the heart of healthcare is communication, is not to lose our humanity. And if we can't treat people with dignity and compassion, despite all the digital tools we're putting in place and the beautiful equipment and the data, we've kind of lost the plot. And I think thank you for that, reminding us of all of that. And hopefully that's a challenge and the privilege we all have as healthcare workers to remember the dignity that we need to treat patients with and the compassion we need to give them. So Lani, and thank you very much, Dion, as well, for the great privilege of being able to address our colleagues today.
Oh, gentlemen, thank you so much. And thanks for those closing remarks as well, Dr. Richard. Attendees, that's it. All for today. I see you same time, same place next week. Take care and please be safe. Bye.
Thank you very much.